Hi, welcome to Pennsylvania Newsmakers, and as always, thanks for watching. Well, it's the end of the academic year. We're going to get an update on what's going on in public higher education, and then our monthly healthcare update. All of that follows these words.
This is Pennsylvania Newsmakers, a fast-paced, unrehearsed weekly discussion with and about the leaders who shape your world. And now, here's your host, Terry Madonna.
Hi, welcome back to the program. Well, the academic year in Pennsylvania colleges is coming to an end. Oh, those finals and the final papers are in. Joining me is Peter Garland. He's the acting chancellor of the state system of higher education and an old friend. Peter, welcome back to the program. It is the end of the academic year. I'm sure, on the campuses, everybody's scurrying around trying to get those papers written, and the exams, I know on the F&M campus that's true, right?
Absolutely, it's going on every day with that. I have two daughters who are in that same race to get those final papers and finals done, so it's an exciting time. All
right, let's talk a little bit. I want to talk about some of the programs and what all has happened in public higher education. But first of all, give us a quick update on the budget. It looks like the recommendation was for a flat budget, no more than last year, at least no big cuts that you had to deal with. What's your expectation coming out of this budget and the hearings that were held?
I think level funding is what the governor proposed. I think is probably what's in the cards for us in the future. Certainly compared to the past 2 years, where we sort of worked back to sort of get to the point of level funding. I think it's a good place to start in the conversation. Still is, as you know, in higher education with increased costs and that kind of thing. It means campuses are going to have to look very carefully at what stays, what goes, and how to continue improving.
Some costs you can't. Pensions and healthcare costs. It's hard.
We have all that.
Yeah, you don't have a lot of flexibility in a budget. All right, well, we'll keep folks posted. We'll do some upcoming programs in June when they get down to the budget. All right, look, public higher ed, you're the access point for thousands and thousands of students, regional universities. Talk a little bit about what you would view as the accomplishments of the past year, the highlights of the past year.
Sure, and as you say, access point. I think a couple things that to point out is it's not just coming to our campuses anymore in terms of accessing the education. The Venango campus of Clarion University is now Venango College, a more full-service site for students in certificate, associate degree programs, and the first 2 years towards a baccalaureate.
So expanding even more into the communities.
Into the communities.
Good point.
East Stroudsburg's opened a center in Bethlehem that'll be a better service to the Lehigh Valley for students there, and to work with the community colleges for those students who want to transfer to 4-year. And probably the biggest one is we actually dedicated a new multi-university center, Pashy's Multi-University Center in Philadelphia, starting with a lot of strong programs that Cheney University has been offering on that site. Now East Stroudsburg, Westchester, and Millersville will be added next fall, and we hope to expand even more programs to serve huge populations in Philadelphia that need affordable baccalaureate level education.
Yeah, as you know, we're going to have the folks from Highmark on in a minute or two. We're going to talk a little bit about some healthcare update, but nursing, the need for nursing. You're trying to meet that need as well, I understand.
Sure. It's in allied health and nursing, we've been expanding programs. I'm proud to say that right now 2 of our universities, Indiana University and Bloomsburg University, have the highest test scores for the nursing tests, so are producing high-quality nurses for Pennsylvania. Certainly, nursing is not the only place we expand. A lot of this sort of science areas, we've been trying to expand our offerings.
Yeah, one of the things that we hear all the time, and I'm in higher ed, been in that business all my life, is how you match the skills in the workforce for the typical programs that colleges and universities offer. Public universities more known, I think, for professional programs. What's the situation? How are you addressing the need in that area?
First of all, you've got to look at your market. You've got to look what the regional and state economies want. We know most of our students come from Pennsylvania and want to stay in Pennsylvania to work. So it's very important for us to look at what are the enduring as well as expanding areas. Certainly, as Marcellus Shale came online, we expanded programs in natural gas production at the associate level, safety science, all the way up to the PhD level to make certain that as those industries expand, they have talented people that can help maintain the safety and environment environmental controls that are necessary. So we look to continually look at where is Pennsylvania's economy headed, and how can we create opportunities for students to be part of it.
Okay, we're going to run to a break. There are obviously some big challenges that the public all higher ed faces. We're talking with Peter Garland. He's the acting chancellor of the state system. We're going to talk about the future challenges. Full disclosure, I'm an alum of one of those schools and spent, I won't tell you how long, as a professor at Millersville University. We'll be back in a moment.
This broadcast of Pennsylvania Newsmakers is presented by the Pennsylvania Chamber of Business and Industry, the statewide voice of business, and by the Pennsylvania Business Council Education Foundation, educating citizens and business leaders about important public policy issues and civic affairs. This broadcast of Pennsylvania Newsmakers is brought to you by BetterSaferRoads.com. To voice your support for safer highways and less traffic congestion, visit BetterSaferRoads.com. And by the Pennsylvania Manufacturers Association. Business in Pennsylvania is our business.
Hi, welcome back to the program with Peter Garland. He's the acting chancellor of the state system of higher education. The system is in the process of looking for a new chancellor. The previous chancellor left, took another position in Washington, D.C. We're talking a little bit about, this positioning and the situation of higher ed. I know that lots of folks out there and their families are making these decisions, many of them made about where to go to school. So this is, I think, an important update. But there are some pretty significant challenges out there, as Chancellor Garland will attest to, and let's talk about some of them right now. One of them has to do with aging population in our state, fewer people, in the typical demographic, even though you have a lot of adult programs. Weigh into that a bit.
Yeah, I mean, the Pennsylvania is changing, and we know it's skewing older. We know the number of
grayer, right?
Yes, if you've got the hair. We end up with we've got fewer high school graduates that are moving through the process, and there certainly are challenges in public schools to get more students to be retained to graduation. But we have in Pennsylvania about 1.2 million people that have some college but have not completed an associate or baccalaureate degree. Mm-hmm. So if you think of it from an economic imperative, as well as a critical access for people to be able to better their lives and improve the economy, that's the population that I think is increasingly going to be an important one for us. As I mentioned, why we're moving into Philadelphia, why we're moving off campus, meeting students where they are is critically important.
You brought up a good point. There was a big debate going on, and I know this does affect a lot of students, about this transition, for example, from the community colleges into a four-year school. Typically, many of them would go from a community college into a state system school. Now, that's been embellished and a lot more implementation in the past half dozen years. Say something about that to assure, Yeah,
we've been working, we've had sort of two versions of legislation that we've worked on that we are able to move literally the first 30 credits, we call them the foundation credits, that all students might have at a community college, a system university, and those are in place. And then for the next 30 credits, getting to this 60 credit associate degree, we've worked with community college faculty, our faculty, to make certain there's complete program alignment so students come in truly with their associate degree but ready for their junior year and 60 more credits and they're done with a degree. Yeah. We think that's important, that it's not just any 60 credits but those that actually get you to your degree.
Sure. And I mean, that was a pretty contentious issue for a while. I mean, when I was at Millersville, we would get the transcripts and, you kind of feel, for the students who've spent time in community colleges, and there's the faculty who evaluate and want to make sure that it sounds like it should be easier than it is, but it's, as Meryl Streep might say, it's a little more complicated, right? But you're delighted with the progress
Yes.
so far?
Yes. I mean, we're delighted so far. There's certainly more work to be done in that area so that students know what they need to do, move through that process, and get on with their lives.
Yeah.
Increasingly, I think it's going to be a lot of students taking, in a sense, stackable credentials. They're going to come for a 2-year associate degree and know that they have the option of moving on to a baccalaureate, but may go back into the workplace full-time.
And then come back.
Part-time or full-time. That's the student of the future.
And there's nothing, and actually, what's wrong with that? I mean, they ought to go get, I mean, you know, a lot of students working, you know, they're going part-time. That means that classes have to be available in the evening. You need facilities to do that. And the structure of higher ed is just not the 8 to 4 that a lot of people might traditionally think about, right?
Yeah, I mean, that's the challenge across the country, not just for us, is that increasingly students have very complex lives, multiple commitments, and they want the education sort of when they want it and where they want it. And it's our obligation, I think, in terms of serving Pennsylvania, to create those access points that make sense for students.
All right, look, I want to thank you for coming in. It's been very helpful. We'll have you back in the fall. We'll get a look at the beginning of the academic year. We'll see what goes on. All right, it's time for our monthly health care update. The cost of, I almost said higher ed, they're going up too, but also the cost of medical services and health care in general. We got a couple of experts on the program. We're going to chat about those. You're not going to want to miss this. After talking about money, we pay some bills.
This broadcast of Pennsylvania Newsmakers is brought to you by Pennsylvania Credit Union Association. Pennsylvania Credit Unions, where people are worth more than money. To find a credit union that is right for you, check out ibelong.org. And by the Energy Association of Pennsylvania, Pennsylvania's energy information source. This broadcast of Pennsylvania Newsmakers is presented by the State System of Higher Education. 14 state-owned universities. The state system is the largest provider of higher education in Pennsylvania. And by the Hospital and Health System Association of Pennsylvania, working towards a healthy Pennsylvania.
Welcome back to the program. Well, it's time for our monthly healthcare update. We do this. Dr. William Bloschichak, he's the Senior Medical Director at Highmark, is here along with Dr. William Bird. He's the Associate Chief Medical Officer at Penn State Hershey Medical Group. Well, they sound like professors. They got these long titles. But look, guys, we're really glad to have you here because let's start with you. Rising costs. I mean, every day that's all you hear about. Costs going up. It's not that the quality of medicine isn't good. I think most people rate their physicians very highly. I've done surveys on this. What can be done to contain the cost?
And thanks for having us, Terry. One thing that we're doing is we've advanced this patient-centered medical home effort, and we've had a pilot on that. Believe it or not, over the first 9 months of the pilot, we were hoping for just a reduction in the care cost trends.
Right.
We actually had a reduction in the care cost by almost 2% in this medical home effort.
So, okay, you get the tough job here, Dr. Bird. A medical home. What does that mean? Tell our viewers.
Medical home is a concept that actually goes back to the 60s through the Department of Pediatrics, but around 2000 it looked at the future of family medicine, did a pilot, and came to the concept of what do you do, how do you take care of people better, not just based on cost, but based on quality and access. And that became this concept of medical home, which is a place where you can get your care coordinated, and really measure quality, outcome, access, advanced communications with electronics, and care transitions with care management to try to do a better job, especially in chronic disease management. Right. It's very disproportionate on where the expenses lie. 50% lie in 10% of the people, 80% of the costs lie in 20%. Care for people differently and measure your outcomes, and you can decrease your cost. And those models have been shown, they've been done elsewhere.
Is it one-stop shop? I mean,
it's coordinated shop. It's the ability to coordinate.
You might have to go different places, but it'll be...
You still need specialty care, but those referrals are made, and the communication between primary care and specialty is essential. It's also very important to keep primary care rejuvenated, that you have a model that the medical students want to go into.
All right, now you get another tough job. I want you to take a patient, and let's say the patient has a coronary problem, and they would come into a medical home. Just sort of go through 3 or 4 things that you would do that amplify what Dr. Bird talked about, just so our listeners can get a really good feel, or viewers. We got listeners too, but viewers as well. Go ahead.
And you know, Terry, I'm one of those old family doctors. I still consider myself, and in many ways, I view this effort as back to the future. In that, when I practiced, the family doctor coordinated your care. You still saw your cardiologist, your specialist, but everything was coordinated through that family doctor. He was or she was your primary doctor, and it's a transition back to that model, but almost back to the future in that it's that model we're using today's tools, today's communication efforts, electronic health record. Right. So that patient that has a heart attack or so, the patient would be in the hospital, but before the patient left the hospital, there'd be coordination of care between that team in the hospital and that practice such as Dr. Bird has with patients' medications, patients' treatments. And unfortunately, we had gotten away from that a little bit. And that leads to duplication of services, leads to patients not understanding their medications often, and it leads to readmissions often. And that coordination of care and that primary care taking the lead on coordinating has shown higher quality, better access, and reduction in costs.
How widespread is this?
It's growing and starting. We're still living in a fee-for-service world, so it's hard to fund this. So you need to invest in this to be able to grow it and be able to show a savings, which then hopefully those savings come back to help fund it.
Yeah, okay, we're going to run to a break, but when we come back, I mean, it seems to me, and you know, I'm a patient. You guys are the experts, but I think now I see a lot more coordination just when I go to my family doc. There's a lot more coordination in medical records. I can get online. Right. I like the fact that I see the results. When they come up, I can interact. I mean, I think is that the kind of well, hold that with the producers. Remember, we're going to go to a break. We're going to continue with this discussion, and then we're going to find out, you know, some patient experiences at one medical facility in our state after these words.
This broadcast of Pennsylvania Newsmakers is presented by Highmark Blue Shield, changing the way health plans work for business with a variety of plan options for employers and more choices for employees. Information is available at highmark.com. Have a greater hand in your company's health. And by the Pennsylvania Healthcare Association, the future of long-term care.
Hi, welcome back to the program. Well, we're involved in, I think, a very important discussion of the changing nature of medical care and how it's done. And you, Dr. Bird, you were making this point about the change from one kind of system about how you get paid to a patient-centered. Repeat that for me. You said this in the break when we were chatting.
Currently, most healthcare is paid on a volume model. The more that you do, the more reimbursement you get. In a movement in this medical home, it's really based more on outcome and incentives, controlling costs with high quality. It's not just a cost reduction model. So you really have to incentivize. You get what you incentivize. And if you incentivize volume, you'll get volume. If you incentivize quality, you'll get quality.
Overall, in the whole healthcare system, I mean, I want to come back to you and ask you specifically about what your facility is doing, but you know, the Affordable Care Act, I mean, most Americans, and I pulled on this, support universal coverage. We're okay with that. Everybody's, you know, not everybody, but you know, but it seems like we're looking, and you're involved in this directly because of what you do. You're providing insurance. The cost seems to be going up all the time. Do you see any way to restrain those costs?
I do, and it gets back to what Dr. Bird said, in that we need to change the payment model a tad bit, and we need to incent for patient quality, safety, coordination, and some accountability in curtailing costs. And in this medical home model, we do just that. We incent for quality metrics,
Right.
but also we provide Dr. Bird and his practices with data on the population, on their utilization, on their care costs, not just at their centers, but the total care costs.
Sure.
And when physicians see that data for the first time, it really is enlightening. When they see the total cost of care for each patient and for the population. And that's how we incent. And so as they improve quality, access, and control the care costs, they're incented more.
At your facility at Hershey, are you seeing patient outcomes any better because of this? I mean,
Absolutely.
ultimately, isn't that what it's about?
Yes, and absolutely. We started this about 5 years ago going down the medical home road. And if we look at our quality outcomes that are measurable, especially in our chronic conditions, it's significantly improved. That's measured not by just ourselves, but by the payers who will look and deliver us our quality metrics. And we've built new systems. We've added nurse care managers that are going to contact you. If you're in the hospital, you're going to get a call within a day or two from our service to be able to talk to you, make sure you understand your medication, make sure your appointment is made within a week so that you can see your physician. Those things have been shown to decrease readmission, decrease cost, and improve quality. People don't want to be readmitted. They want to stay home and be healthy.
Yeah.
So if you build the system to do that.
Well, that's a good point. I mean, yeah, I won't get into the details of my health care, but I had a medical treatment, and I thought I had a problem with it, and it turned out it wasn't. But I got the call back, you called and said, and that was a couple of weeks later, and I thought, that's not a bad idea, even though it's a couple of weeks later, somebody was there going to say, okay. Are you optimistic that overall with this, that this is going to have a huge impact on cost, or do you think, I mean, obviously other things have to happen as well, right?
Yeah, I'm very optimistic. And obviously there'll be a leveling off over time, but I'm very optimistic. And as I said earlier, our pilot, we were just trying to get care costs in line with inflation.
Right.
And it actually ended up with a reduction in the care costs in the beginning.
Well, I just read where healthcare costs this year have shown, I think, the sharpest decline. They're down to what, three and a half?
Yeah, between 3 and 4.
3 and 4%, where they were 7, 8, 9. And what's the reasoning for that?
I think it's multifactorial. I think overall the economy has done a little bit there. But I do think that there is a strong component of this coordinated in more comprehensive management and care at the primary care level.
And you think that's working?
I think so.
Recession. I read in the healthcare literature, fewer people seeing their family doc, putting off visits, going in for medical care. Is that true?
I think that's true, and that's one of the reasons, especially in chronic disease patients, you need to become proactive. Medicine's more reactive. I take care of you when you come. In this model, you have to move out and be proactive and contact you to make sure that we get you in, get your preventative maintenance, get the things you need to do, keep you healthy, much more of an outreach. Again, if you go for the biggest concept, this thing is called patient-centered medical home, and the shift is from a provider-centric model to one that's patient-centric. What does the patient want? What do they want? Increased hours, increased access, increased communication, increased availability. That's what people want.
And final question. Overall, then, are you reasonably confident that healthcare costs can be restrained under this model?
I am reasonably confident.
Okay.
And I think patients want it.
Yeah.
In 6 months, we have 130,000 patients in central Pennsylvania in this now.
Well, this has been a wonderful update. I think this has been important for our viewers. I'll end on that. We're going to force you guys to come back and bring us up to date on this. We'll see you next week for another edition of Pennsylvania. And as always, stay well.